Thanks to everyone on the line. I think we're just going to give it another minute or two just to allow a couple extra participants time to phone in. So thanks for your patience. We'll be introducing the webinar in just a moment. Okay, we're going to get started. Good afternoon, everybody, and thank you very much for joining us today. My name is Conrad Amenta, and I'm the Director of Health Policy here at the California Academy of Family Physicians. At CAFP, it's our goal to make sure that you have the most timely and useful information to help you navigate MACRA's complex requirements, and also to make the most of its opportunities. So as you'll hear in a moment, as Leah takes us through the presentation, there are several tangible steps you can take right away to prepare. And it's been our priority here to identify those steps and to clarify them for you. I know that MACRA has flown a bit under the radar lately in all of the discussions about health reform and potential changes to the Affordable Care Act. It's understandable if perhaps you thought MACRA itself might be subject to change or to repeal. But what's important to keep in mind is that MACRA is separate from the Affordable Care Act and was passed with bipartisan support. It's somewhat unique in that regard lately, and it's going to have a real impact on physicians. So I want to encourage you to check back with CAFP often. We have a section of our website. It's www.familydocs.org/QPP. So that's familydocs.org/QPP. Please check in on that section on the website throughout the year for resources. We're constantly developing and curating new resources to help you navigate MACRA. If you're not already signed up for our bi-monthly newsletter, which is called Academy in Action, you can do so by sending us an email at cafp@familydocs.org. Just shoot us an email, ask to sign up for Academy in Action. We'll make sure you get on the list. And Academy in Action, again, curates a lot of the latest on MACRA and our resources. So we know that new guidance is emerging all the time. We try to connect you with that in a really timely way. At this time, before we get started, I just wanted to call your attention to the chat function for this webinar. So if you look along the bottom of your screen, you're going to see a speech bubble that says chat. So feel free to click on that and type into the text box that appears at any time during the webinar. We'll all see your question, and we're going to answer those questions at the end of the presentation, but please feel free to enter questions at any point during the presentation. And so without further ado, I'd like to introduce Leah Newkirk, who is our MACRA expert and is going to take us through a family physician's guide to understanding MACRA's quality payment program. So thank you again for joining us, and over to you, Leah.
Thank you, Conrad, and welcome everyone to today's webinar on the Quality Payment Program. Again, I'm Leah Newkirk, and I'm a consultant at LSN Health Strategy, but also a former staffer at the California Academy of Family Physicians, and very happy always to be continuing my work with family physicians, especially as you tackle these complex changes. So MACRA creates the Quality Payment Program, and the goal of all of this is to move Medicare away from a strict fee-for-service program toward a more value-based payment program. And our goals today are to walk you through the quality payment program, and this should serve as a good introduction to that program. But we're also going to dig a little deeper and help you to develop a strategy for reporting in 2017. Next slide, please. So as you may know, MACRA and the quality payment program have two pathways for physicians. The first track, and the track that the majority of physicians will be on at the start of this program, is the merit-based incentive payment system known as MIPS. Now, MIPS takes fee-for-service as a baseline, but then adds bonuses and penalties that are tied to certain performance categories: quality, cost, advancing care information, and improvement activities. MIPS also consolidates existing quality programs: PQRS, meaningful use, and the value-based modifier. The second track is called the Alternative Payment Model Track, or APM. And these are payment models that give incentives to providers to provide high-value care. And more importantly, there's a subset of APMs called advanced APMs. And as you'll see, these are what really pull you out of MIPS and into this other track if you're in an advanced APM. And these are APMs where providers are required to take on some risk. Next slide, please. So as you are thinking about which track you might be on, the first question to ask is, am I a MIPS eligible clinician this year, this first performance year? MIPS applies to Medicare Part B clinicians, and that includes family physicians, but it also includes physician assistants and nurse practitioners, others who may be in your practice, as well as other specialists. And if you're a Medicare Part B clinician, you're likely in MIPS unless you fall into one of these exemptions. The first is that you're newly enrolled in Medicare. You're in your first year as a participating Medicare provider. The second is that you're a low volume provider, and that means that you have $30,000 or less in Medicare charges annually, or 100 or fewer Medicare patients annually. That will pull you out of the MIPS program. The third is that you're participating in an advanced APM. Now, physicians who are in that low volume category historically should have received a notice from CMS in December. So they are trying to alert people who may be in that category. Exempt physicians receive the annual fee schedule update, but will not receive the bonuses or penalties that are associated with MIPS performance. Next slide, please. So APMs, advanced APMs, I should say, are very specifically defined in the final regulations that CMS published. And they're listed here. There's a couple that aren't listed here, but they are really inapplicable to California family physicians. The two others include the Vermont joint replacement model, very recently added onto this list. So you see that there are only 5, now 7 advanced APMs in this performance year, and only the top 3 there really include primary care physicians. And then we don't have comprehensive primary care plus in California. So it's only in the top 2 categories, the Medicare Shared Savings Program, Track 2 and 3, and the Next Gen Accountable Care Organization model, where we'll find California family physicians. And I'm just gonna list them out because they're a very limited number. We have 2 Medicare Shared Savings Program organizations in California that are in Tracks 2 and 3. That's Scripps Accountable Care Organization, and Torrance Memorial Integrated Physicians. There are 9 next-gen ACO model organizations in California, and these include APA ACO, HCP ACO, Hill Physicians Medical Group, Memorial Care Regional ACO, Monarch Health Plan, National ACO, Prospect ACO, Regal Medical Group, also called Heritage California ACO, and Sharp Healthcare ACO. Now, the qualifications for advanced APMs are going to be reset each year, so you may not be in one of these programs this year, but you may be, there may be a broader group next year, and you may find yourself in one of those organizations next year. So each year, qualifications are reset. Next slide, please. But for now, at least, in this first performance year, most California family physicians are MIPS eligible clinicians. CMS has projected that there will be about 712,000 clinicians participating in the QPP, and only 10 to 15% of those are projected to be in advanced APMs. In future years, CMS intends to broaden opportunities for clinicians to participate in advanced APMs. And as you'll see later in the webinar, there are incentives, certainly. CMS is pushing everyone in that direction with this program. So expect to see more clinicians in advanced APMs in future years. Next slide, please. Now, for MIPS eligible clinicians, this is CAFP's key takeaway for today. We want all MIPS eligible physicians, all California family physicians who are MIPS eligible, to submit data for 2017 and avoid a 4% penalty to your payment in 2019. Key takeaway, so keep that in mind, and we'll walk you through your options for reporting for this year. There are 3. The first is that you can test the program. Just report some data for some period of 2017. That can be just one quality measure or one improvement activity, or the 4 to 5 what are called base measures for the advancing care information category. There's no minimum reporting period, and then you don't get that payment penalty in 2019. The second option is to participate for 90 days of the calendar year, and you'll participate more fully in the MIPS program, but you just have to be ready for that sometime before October 2nd. If you're ready by October 2nd, you still have 90 consecutive days in the year for measurement. And then you have no penalty, and also the potential for some positive adjustments. The third option is to participate for the full calendar year. And then you have greater potential for an even greater positive adjustment. Now this slide says submit data in 2017. That's actually a mistake. It should say for 2017. You submit data by March 31st of the following year. So March 31st of 2018. It's sort of similar to the PQRS, or Meaningful Use Program, for those who are familiar with those. Next slide, please. Now you can report in the MIPS program as either an individual or as a group. A group is defined as a set of clinicians who have a common tax identification number, TIN. And whether you report as an individual or group determines the mechanisms that you have for reporting. So if you're reporting as an individual, you can report through Medicare claims. if you're reporting as a group, it opens up this opportunity to report through the CMS web interface. But your strategy with reporting will vary depending on whether you're going at it alone or going at it as a group. Your payment adjustment, if you're reporting as an individual, will obviously be tied to your performance solely. And if you're reporting as a group, it's sort of an averaging of the group's performance. Next slide, please. These are the 4 performance categories that, taken together, will lead to your composite performance score in the MIPS program. Quality, cost, advancing care information, and improvement activities. Now, 3 of these align with current programs. Quality really draws on PQRS, cost on the value-based modifier, advancing care information draws on the meaningful use program. So get used to that new terminology. Advancing care information is meaningful use. And improvement activities is a 4th category added to this program that's totally new. But note, in 2017, well, in every year, these 4 categories will be weighted differently to get to your composite performance score. And in 2017, in this first year, cost is out. Cost will not be measured this year. Quality, on the other hand, has a heavy weight of 60% of your score. Advancing care information, the new meaningful use, is 25% of your score, and improvement activities is 15% of your score. Now, this is going to change over time with increasing weight on cost, ultimately getting to 30%, and quality diminishing in importance over time to your overall score. But this is for the first year. So these are you should be thinking about the 3 categories that are weighted primarily. Next slide, please. Now, quality, 60% of your overall score. Most participants will report on 6 quality measures, which is actually a reduction from PQRS, and that will include 1 outcome measure. There's a lot of flexibility in measure choice. There's over 270 measures to choose from, but something like 56, I believe, in the family medicine measure set. You can choose any, but CMS has culled that down into different specialty measure sets so that family physicians can go right to the family medicine measure set and see the quality metrics they're most likely to use. There's no domains, no cross-cutting measures, and bonuses are available for those who report through EHR, a qualified registry, a qualified clinical data registry, or the web interface. So that's anything basically but reporting through claims. CMS wants to move everyone towards these electronic reporting mechanisms. Next slide, please. Advancing care information, drawing on meaningful use, 25% of your overall score is, you have 2 components to your scoring in this performance category. There's a base measurement with 4 to 5 metrics, and then there's performance scoring based on up to 9 measures. So you basically have to report on these 4 to 5 base measures. And these are, you have to conduct a security risk analysis, e-prescribing, providing patient access to a portal, sending a summary of care, and requesting or accepting a summary of care. And then you can choose to submit up to 9 additional measures for credit. There are fewer measures than in the meaningful use program. The CMS was under a lot of pressure to streamline the older quality program. And again, bonuses available for registry reporting and reporting through certified EHR technology. Next slide, please. And this third new category where you're being measured 15% of your overall score this year, it provides credit for practice innovation. You choose from 90 improvement activities that are in 8 categories, and the number that you should participate in depends on your size and location. If you're a medium to large practice, you're going to select up to 4 improvement activities for a maximum score. If you're in a practice that's 15 or fewer clinicians, if you're in a rural area or a health professional shortage area, then you choose up to 2 activities for maximum credit. If you are in a certified medical home or a group that's a MIPS APM, you're not an advanced APM, but you're a MIPS APM, then you get full credit automatically in this category. So if you're NCQA qualified, certified medical home, you can get full credit for improvement activities automatically. Next slide, please. And then cost. Again, not a part of your overall composite score in this first year. However, you will receive reports on your costs this year, and we highly recommend that you review them. It'll give you important information for coming years. And as you know, there's often errors in claims-based reporting. So we want everyone to get used to reviewing, checking the information calculated by CMS for errors. Cost will measure 2 areas: total cost per capita for all attributed beneficiaries and Medicare spending per beneficiary. It's Part A and Part B. Part D drug costs will not be included in this calculation. Next slide, please. Now back to alternative payment models for just a little bit. Again, we have these different categories of alternative payment models, and that first one we went through in some detail. That's the important one. That's the one that pulls you out of MIPS. And those are the APMs where they're taking on some risk. There are other categories that are qualified medical homes. They have a kind of lower risk structure, but still will be treated as advanced APMs. However, there are no qualified medical homes that fall into the definition, the complicated definition established by CMS in the final regulations this year, but this might be something that we'll see in the future. And of course, primary care physicians will be running those medical homes. And then there's this third category of MIPS APMs that do not get the APM exemption, but receive favorable scoring, for example, full credit in the improvement activities performance category. Next slide, please. This is a little information on how CMS decided who are advanced APMs and created that list. You have to be using an EHR, quality reporting measures similar to those in the MIPS program, and then this is the big one. The organization has to bear more than nominal risk for monetary loss. Additionally, if you are participating in an advanced APM, you must see most of your Medicare patients or payments flow through that APM to get this advanced APM exemption. You must receive 25% of Medicare payments through the advanced APM or 20% of Medicare patients through the APM to be officially an advanced APM eligible clinician. Next slide, please. And these are the advantages to participating in an advanced APM. In the first years of the program, you receive an automatic bonus payment of 5%. And that's bigger than most MIPS physicians are going to see in the early years of the program. You also will start to see annual updates that are higher than those in the MIPS program. So 0.75% for advanced APM participants versus 0.25% for MIPS participants, and that will build on itself over time. And then you are exempt. Maybe the biggest advantage right now is that you're exempt from the MIPS program and all of the hassle of the reporting requirements that we're discussing. So you see here CMS really trying to push folks in this direction ultimately. We'll see if they're successful. Next slide, please. So now I'm going to switch gears a little bit, and in this next section of the webinar, talk about developing action steps and a strategy for reporting in 2017. The first thing you should do after this webinar, which will give you an introduction to the program, is to explore two sites here. The first on the left is CMS's Quality Payment Program website, and you see the URL right there, qpp.cms.gov. This is really a user-friendly site and way to explore and learn more about the program and the metrics. I know I wouldn't say that about many CMS websites, web pages, but this really is a helpful place to go to learn more about the Quality Payment Program. And then on the right, definitely visit the AFP's MACRA Playbook website. Very helpful and tailored to California family physicians and their needs vis-a-vis the Quality Payment Program. For example, the AFP has pulled the family medicine measure set for the quality category, and you can just check that out there. And the URL for the AFP's QPP site is on the right at the bottom of the screen. Next slide, please. So in terms of developing a reporting strategy for this first performance year, I'm going to again reiterate our key takeaway. Have a strategy, plan to submit some data. It's very easy to participate in this first year in particular. That is because you have this option of just testing the program. And that means, again, you can submit on one quality measure, on one improvement activity, or on the 4 to 5 base advancing care information measures. You have the second options, participate for 90 days of the calendar year, participate for the full calendar year. And I want to help you think through in the next few slides how to pick your option here. So next slide, please. And these are the steps that I would take. First, identify whether you're going to be reporting as an individual or group. Identify your reporting mechanism. Evaluate your experience with PQRS. Review your QRUR quality resource use report and PQRS feedback report. Evaluate your experience with meaningful use, and review the quality advancing care information and improvement activity metrics. So I'm going to go through this in a little more detail now. Thank you. Again, you want to evaluate whether you should report as an individual or a group. And note, this is important to your development of strategy. Physicians reporting as a group must report on the same measures across all 4 performance categories. Again, so you're picking 6 measures from 270. You have to work together to pick the ones that the group will perform well on as a whole. And selecting this, dictates the next step, which is identifying your reporting mechanism. Next slide, please. Now, you don't need to use the same reporting mechanism for the different performance categories. You can use different mechanisms for each. And on this slide and the next slide, you'll see them listed out for individual reporting and for group reporting. If you're considering EHR, you're using your certified EHR technology as a mechanism, highly recommend that you contact your EHR vendor and ask them, first, is this certified EHR technology? Second, is it a 2014 or a 2015 edition? Because that will affect reporting measures. And third, what are they doing? What is your vendor doing to support MACRA reporting? Because it could be that they're offering support assistance to help get you going with MACRA. They should be. You should also know when it comes to the QCDR, the Qualified Clinical Data Registry here, that there is the PRIME registry available through the American Board of Family Medicine, and opportunities to access this registry as a member of CAFP and AAFP. So feel free to contact me or Sonia Contact, the Manager of Medical Practice Affairs at CAFP, if you want more information on that. Next slide, please. Now, next step in the self-assessment to help you determine which reporting option to choose is to evaluate your experience with PQRS. Again, the quality performance category draws on the PQRS program, and quality is 60% of your score in the first year of the quality payment program. So did you participate in the PQRS program and submit data for 2016, or are you planning to? I know the deadline for that is coming up. Are you comfortable with PQRS reporting and PQRS measures? This will also help you develop a strategy because you'll see how you did in different metrics of the PQRS program, and it may help you select quality metrics for the QPP. Next slide, please. Then you want to review your quality and resource use reports and PQRS reports. Again, getting sort of similar information. It'll show you where you're doing well, help you identify measures to select, and help you evaluate how ready you are for full year reporting versus 90-day reporting. Now, if you haven't participated in PQRS in the past, we still encourage you to move forward with quality payment program, but you're more likely to select that option of just testing the program, just reporting on one quality metric for this year. We have heard that the QRUR reports, which have great information, are difficult to access. We have the CMS Enterprise portal here in this slide where you can get to them. You need an Enterprise Identity Data Management account. It's a little complicated to get into now, but again, contact me or contact Sonia to assist you if you need assistance in accessing these reports. Next slide, please. You should also evaluate your participation in the Meaningful Use program. Again, this is the Advancing Care Information Performance category draws on meaningful use, and that's 25% of your score in the first year of the program. So do you have certified EHR technology? Did you participate in the Meaningful Use program and submit data for 2016, or are you doing so in the next few weeks? Next slide, please. Now, The next thing you should do is explore the metrics in the 3 categories that are measured this year. And I'm going to give you a taste of those metrics today and some information on where to learn more. The first place you can go is to CAFP's website again, where you can see the list of quality measures for family physicians and the list of improvement activities there. Next slide, please. But here are some examples. These are just a few of the 271 quality metrics that you can choose from. Again, you're going to be selecting 6, and there's a narrower set, 56 quality metrics in the family medicine measure set. So these are the titles of the metrics. They don't give you a whole lot of information. But I'd invite you to go to the qpp.cms.gov website, that website we spotted earlier in the slides here. You can explore the measures. There's a category at the top, explore measures there. Now, for example, if I click on adult kidney disease blood pressure management on that site, I get a description of what they want measured, and that is percentage of patient visits for those patients aged 18 years and older with a diagnosis of chronic kidney disease, specific stages, with a blood pressure less than 140/90 or greater or equal to 140/90 with a documented plan of care. So just an example of a measure, what CMS is looking for. They'll tell you on that website the measure number and whether it's an outcome measure. Again, you have to select 6, and 1 has to be an outcome measure in this performance category. And as part of your self-assessment and determining your strategy for reporting this year, you and potentially those in your group want to look through these measures, see what measures you're comfortable with, what you've perhaps used and done well in PQRS, and understand your comfort level as a group if you're doing group reporting, and identify the 6 that will work for you or your group. Next slide, please. These are all of the advancing care information metrics. I should have highlighted, again, there's this base score and there's 9 additional metrics that you can report on. If you report on all 9, you get maximum credits. The base metrics are e-prescribing, provide patient access, request accept summary of care, security risk analysis, and send a summary of care. And again, these are just titles for the metrics. You can go to that qpp.cms.gov website and explore measures. And in this performance category, you could click on these and learn a lot more about each measure. So for example, if I click on e-prescribing, one of the base measures, I learned that it is required for the base score, but not for performance score. And it tells me at least 1 permissible prescription written by the eligible clinician is queried for a drug formulary and transmitted electronically using certified EHR technology. All right. I won't go through more of these for fear that you'll all fall asleep, but this is just to give you a taste of these measures and where to go for more information about them. Can you go back? Actually, I do want to, again, go through it with improvement activities. So these are examples. Again, this isn't the complete list. There are 92 improvement activities. Most participants are going to choose 4. If you're a small practice, a rural practice, or in a health professional shortage activity area, you're going to choose 2. And again, these are the titles of the improvement activities. A lot more information is available on the QPP CMS website. So for example, here, if you choose care transition documentation practice improvements, you get an explanation. That is implementation of practices, processes for care transition that include documentation of how a MIPS eligible clinician or group carried out a patient-centered action plan for the first 30 days following a discharge. It tells you how this is weighted and the subcategory name. So more information on that site, a great place to explore and begin selecting the metrics that you're comfortable with this year. Next slide, please. And so that ends the description of the metrics, which I know can be tedious and certainly hard to listen to on a webinar. Strongly encourage you to go to that site and start your explanation. It is very user-friendly. And then CAFP, as always, is a great resource to family physicians hoping to learn more about this program and hoping for more guidance on, specific things to do here to develop your strategy and your reporting approach. So we have resources coming, Quality Payment Program 201. We have Quality Payment Program for Small and Rural Practices under development. And just a note on that, CMS has announced some organizations that will specifically be helping small and rural practices get ready for the Quality Payment Program, and CAFP will have a lot more information on that shortly. They just made the announcement this week, or maybe last Friday. We'll get that information out to you as soon as we can. And then, of course, there will be programming at CAFP's all-member advocacy meeting. That's March 4th or 5th. I'll be there along with Ashby Wolf, who is CMS's Chief Medical Officer for Region 9 and a CAFP member, and a tremendous resource for family physicians who are trying to get a handle on all of this. And then there's programming planned at CAFP's Family Medicine Clinical Forum. That's April 8th and 9th. These meetings are just amazing in and of themselves, but if you're looking for more programming on the Quality Payment Program, then these meetings are the place to be, and you can register for them at CAFP's FamilyDocs.org website. Next slide, please. And with a big thank you and my contact information, I am happy to answer any questions by email. Is probably the easiest way to contact me. So feel free to write and ask questions about the QPP, and I'm happy to be a resource to you going forward as you try to navigate this fairly complicated program. But in the meantime, I want to invite everyone to type your questions into the chat box. Again, it's at the bottom of your screen. There's a chat. You are welcome to type questions in. I will answer them as best I can, and I am happy to get answers to Sonia for those that I don't have immediate answers to. So any questions out there?
Hi, Leah. This is Sonia. First of all, thank you so much for this presentation you just gave. I thought it was very informative, and I hope everybody on the call felt the same way. I encourage everybody, as Leah said, to ask a question in the chat box. It should be at the bottom of your screen. In the meantime, as we wait for some to come in, Leah and Conrad, I invite you both to just, I guess, mention things that you might have heard that you think others would benefit from hearing. And before we start with that, I have a couple questions that I have been asked over the course of the weeks up until this webinar. One came yesterday from a physician who unfortunately couldn't make our webinar, but he was asking whether he was eligible for the MIPS payment system if he worked in a skilled nursing facility.
If he is participating in the Medicare program, I believe the answer is yes. those in FQHCs are kind of pulled out of this, but I think skilled nursing facilities are in if you're a Medicare participating clinician.
Okay, thank you. I will certainly make sure to get back to him and let him know. It seemed to be a little bit of a gray area, but I think that's safe to say that if he's seeing Medicare patients, he should be in it or eligible for it. Another question that I think some people were asking was either when or how will they know if they have a low volume threshold or if they meet that status?
So CMS was supposed to have notified everybody if they were in that low volume category historically in December. So if you did not receive notification from CMS, I want to be careful here. I mean, you are probably not in that low volume exemption. However, often in busy practices, I know these kinds of notices can be missed. You can contact CMS about that. And I would recommend contacting Ashley Wolf. But let's plan to get the group some CMS contact information to ask that kind of question.
Sure, I'm happy to help with that. Do you know how they're contacting by any chance physicians who do meet this threshold?
So they were supposed to have sent out letters.
Okay.
And again, this is a little tricky because the letters were sent to physicians who fell into that category in a period of time in a year, I think it was September 2015 to August 2016. Now, what matters is whether you're in that low volume category in 2017. But the historical data should give you a sense of, what kind of volume your practice has had in the past. And you might want to, do some thinking about, if you're just on the line, how much Medicare you're taking. I know these are very tricky questions, but something to think about if you want to be in that exempt category.
Okay, thank you. And then one last question that I have that I don't quite know the answer to is, what if physicians change the groups that they're in during the performance period?
I knew the answer. I knew the answer once when I was reading the regulations. I was trying to think of it now, and I might have to get back to the group on that question. I mean, I think that the answer is that they will use the portion of time. I mean, they'll apportion your time. So I guess the question is, if I'm a MIPS physician, and I'm in one group and then another group, and I'm doing group reporting, how do I manage that switch? There's this other question of if I'm a MIPS eligible clinician, I join an advanced APM, how will I manage that switch? And let me plan to just write up an answer to both questions and get that to you to distribute to the participants.
Okay, sure. That sounds good. Okay, so at this time, I would like to invite both you and Conrad to just kind of mention key takeaways or key things that you've heard for our participants on the line still.
Thanks for that, Sonia. Sorry, go ahead, Leah.
Thank you. I think Conrad made a really important point at the start of the webinar, and that is that there's a lot of confusion about MACRA versus the Affordable Care Act, which, as we know from the news, is really under threat, like it or not. And, MACRA is a distinct program, and in my opinion, is here to stay. It's never been the target of Republican or Democratic criticism, and never, no mention of repealing this. It would be a tremendous lift for them to repeal this, as it is for the ACA too. But no sense that this is going away. So we have done some polling and seen that there's that confusion, but also just a lack of knowledge about the quality payment program still, even though we're in this first performance period. People may be aware that payment changes start in 2019 and maybe less aware that they're based on this year, this 2017 first performance period. So just encouraging everyone to learn more, and to encourage your colleagues, those in your groups, to learn more about this program.
Thanks for that, Leah. If I can add something to that, it would just be that I really encourage the attendees to take a look at CMS's QPP website, because it's actually really intuitively designed. It's really nicely done in the sense that you're able to sort through the quality indicators, and you can find those indicators that are the easiest for you to report, both in terms of the way that it's reported, the platforms you might be able to use to report them. It's really quite nice, especially when you take into account that in 2017, if you report anything at all, you can avoid a negative adjustment. So that to me is my key takeaway, is that CMS, I think, has gone some distance towards making this, easing us into this as much as possible. It looks very monolithic and dense and difficult to wrap one's head around. And the legislation as a whole definitely is. But in the short term, there really are some good on-ramps to being able to ease into MACRA. If you are a MIPS eligible physician, just know that reporting anything in 2017 will avoid any nasty surprises 2 years out, and that the QPP website really is a helpful tool. And the last thing I wanted to emphasize is to please think of us at CAFP as a resource to you. Don't hesitate at all to reach out to us, to call us, to email us. You can contact Leah, whose contact information is on the slide. Myself, I'm Conrad Amenta, or Sonia Contact as well. Feel free to give us a call at our main number and ask for any of us personally, and we're happy to take questions away, do some investigating, get back to you personally, walk you through something if we can, anything we can do to help. So those are my main takeaways, and also just keep an eye on our website, because we keep curating new resources all the time, and we're trying to make this as easy and painless as possible.
I do see a question in the group chat now. Is MACRA only for outpatient? The answer is yes. Yes, sorry, I used Medicare Part B. That is outpatient. Medicare Part A is hospital Medicare payments, and that is not included in this program. However, I think hospital systems should be, if there's any leadership from hospitals on the webinar, they should be thinking about their outpatient clinics. And then not a big issue this year, but your Medicare, your hospital costs attributed to your Medicare beneficiaries will be included in that assessment of your cost in that one performance category. So something to be aware of going forward. As Conrad was talking, it just occurred to me to say too that there are additional sources of support for family physicians out there. We're learning more about what's available to small and rural physicians, and we'll get that information out to you. But just also want you aware of the practice transformation networks, the PTNs, that are out there in California. These can be a source of support for incorporating quality improvement activities in your practice. So with that performance category, they are aware of MACRA. They're supposed to be working in alignment with this program. So the PTNs out there are another support source for family physicians. I see a follow-up question on the outpatient. 4% penalty will be included in inpatient payment. Yes, that's correct. So 2017 is the performance period. If you don't report anything, not even the one quality metric by March 31st of 2018, you will get a 4% penalty, and that's all of your Medicare Part B claims penalized in 2019. So hopefully that answers that question. The lag time is very similar to PQRS, I think, where you have this performance year, and then the payment bonus or penalty will be 2 years away. Something I think groups like CAFP were critical of in our comments to CMS, that there should be a closer tie. But we have what we have.
I think there's one more follow-up question, Leah, if you have a little bit of time.
A question, I don't have an EMR. And if you're in that position, you should definitely be seeking support from CAFP and from these other organizations that are out there for you. You should definitely be thinking about the testing option where you're reporting on one quality metric, one improvement activity. So in that situation, my recommendation is you think about reporting on one quality metric for 2017, and you have the option of using claims as a reporting mechanism. So you can move forward. Of course, would definitely encourage you to think about getting an EMR in place in your practice and seeking support for that from the AFP. But if you're a small or rural practice, some of these organizations that are going to be coming out with support for you. But you still have that EHR, you still have that claims option, and you still have the option to report and avoid the penalty in 2019. And then the question is, which EMR do you prefer? I've always gone neutral on this question. Conrad, I don't know if you want to add anything from CAFP's perspective, but I believe CAFP has always been neutral on that too. It depends on the practice and your needs, I think.
Absolutely. Yeah, I mean, which EMR platform is going to be the most useful to you really depends on where you're practicing, how you're practicing, and what your unique needs are. We don't really have any policy endorsing a particular product or solution. But again, if you take a look at that QPP website, if you're trying to make a decision about where to invest, there is, that may be one of many factors to take into account, is that the QPP website shows you how each quality indicator can be reported. It doesn't really map to specific products, but it maps to types of products, and that might be one decision factor you take into account.
And I think you want to explore MACRA with the vendor. So if you're at that stage where you're thinking about an EHR for a practice, you want to be talking to different vendors from the different companies and ask them, well, how are you going to help me? First, is this certified EHR technology that will work for MACRA reporting? Second, what are you as a company going to do to support me in my MACRA reporting? I mean, it could be helpful to making a decision.
All right. Thank you so much, Leah and Conrad, for going through all of this, both the presentation and the question and answer session. For everybody's information, we will be sending out the webinar slides pretty shortly, along with an evaluation to let us know how we did with this webinar, and with a CME certificate to give you the ability to just record how many credits for your own records. Keep in mind, you still need to report these to AAFP. And unless there are any last thoughts from our two speakers, I wish everybody a great day, and email me if you have any other questions.
Just a big thank you to everyone. It was a pleasure to be on this webinar today, and please feel free to contact me with any questions going forward. Thank you.
Thank you. Thank you, Leah, and thanks to our attendees.
Thank you, everybody.